I'd really like to thank you all for the opportunity to come and speak to you. You'll know that the Irish have a long tradition in Seattle, Tacoma area, and this is a very interesting photograph. When the Irish declared independence from the British in 1919, there was a huge party held in a park in Seattle, and at that time it was declared, they read out the Irish Independence Declaration, and as you can see, it was that long tradition of Irish influence in Seattle has long persisted.
That looks like Dr. Scudian's backyard. I did not know you were an Irishman also.
The only real important disclosure or declaration I have to make is I've never personally had a single intraoperative or post-operative complication. And what I present today is in gratitude to my colleagues, particularly Dr. Dvorak and Dr. Kwan, who've enriched our complications database beyond any expectation. Work like this wouldn't be possible without, the entire team, and that entire team involves the clinical research people, or clinical leads such as physiotherapists and nurse practitioners, our residents and fellows, and then the surgical team who give up of their time and of their expertise in order for us to plug on with this pretty arduous at times dedication to collecting, identifying and hopefully mitigating against complications in spine surgery. So for my talk, I briefly want to maybe have an abstract view of what some benefits may be to putting the time in and identifying and collecting complications. And then more specifically to look at some concrete things that we've done in Vancouver and then beyond, those strategic things that we've done to improve patient care, measurable outcomes that have come from having that broader strategic view initially. So what I'm going to hope to do is take you on a sometimes meandering walk from 2008 to now, and how we've evolved in our understanding of the importance of identifying complications, the ability to recognize them early, preemptive measures, and then management of them. And what I'm going to try and demonstrate is that to start out, obviously, you may have a particular focus on a group of patients or your singular group of patients that you deal with. And as you develop your data and your knowledge, you become a context expert. And with that context expertise, then you can start to disseminate that knowledge. It's with the dissemination of knowledge that you get collaborations. It's with the collaborations with other places then that you start to contribute data to big data and understanding big questions about system problems, identifying issues that are not just unique to your own environment, but to all healthcare systems. And we've done some of all of those in this journey since 2008. And so I'm just going to reflect on some of those things as we move on. First of all, how do you define value? If you want to say there's a value in having a database to identify complications, how do you determine what value is? And I would suggest that value is all about perspective. And what I'm going to try and give you is what as initially was our perspective, and then how that perspective changed over time, and how that perspective was influenced by the people with which we collaborated with, to come to what our current vision is with regard to this work. You might recognize this guy. And it was actually one of his landmark works that raised this really, really important question. In 2010, spine surgeons or the spine community could not have consensus on what even the definition of an adverse event or a complication was. We knew that they were grossly underreported, and we had no idea what effect those complications had on outcome. I'd suggest that we've made some baby steps since then. I don't think we've answered all those questions, but certainly we've made efforts to address some of them. So I went to one of my mentors in 2008 and I said, Dr. Dvorak, I'm thinking that we should look prospectively at collecting complications. And, this was his answer. I can't remember the last time I had a complication, to which his fellow quipped, I can't remember the last time we did post-op ward rounds. So it's all about perspective. And if you look, you probably will find, and if you don't look, you won't find. And how you look makes a difference. because the system that you establish to identify complications will find particular types of events depending on how you set that system up. So malpractice cases typically identify issues around clinical judgment, and patient complaints are typically around issues around communication. And so how you set out to look for the problems or identify the events will determine what it is you find. When you start to accumulate some data on complications, it's critically important to do it in an environment that's non-punitive. You're trying to identify system things that you can address, not point the finger at one or two individuals and say, you have a problem, you have these complications. So it has to be in an environment that's responsive, that's open to discourse, and that's responsive, so that when you identify system issues, that you're working in a place that can respond to what you've identified and make the necessary changes to improve patient care. And I think that when you start to capture values, or when you start to capture data on complications, then you can communicate that to all members of the healthcare team. And that allows you then to deliver value in a better way with quality improvements. And when you've established some quality improvements, and now you understand the benefit of that value, then that understanding allows you to create new value, and that cycle continues. So once you take the step to do something like this, it becomes a very self-perpetuating circle where you can make very, very significant inroads and changes to improve patient outcome. So in 2008, I went to my colleagues and I said, I think we should start collecting data on complications in a prospective manner. And since then, we've evolved into a system that I will admit is time-consuming and labor-intensive, but has enriched our program for all levels of our program and enriched our patients' outcomes, I think, from that dedication. So in the Canadian healthcare system, the public healthcare system, we're lucky to be salaried, and because we're salaried, we can take 4 hours out on a Wednesday morning and discuss every patient and record every single complication. To find that time in a different healthcare environment, in a different system, might be somewhat more challenging, and that brings you to the issue around getting sustained funding for a program like this, something that I'll touch on later. And then we've been collecting this data in a very rigorous prospective manner, and then that's been added to our database, which also includes surgical data, radiological data, and healthcare outcomes data. And typical of any system like this, it's gone through multiple iterations. And we've thought some things were a good idea in 2009 and abandoned them in 2010, only to realize that it was actually a good idea and take it up again in 2013. And that PDSA type cycle or reiteration has to go on, because if you don't allow your system to evolve, then changes that occur in your entire system within your hospital or your OR or on your ward, you won't be sensitive to those changes unless you can allow your data collection system to also change. Right now, when we contribute our data to our database, we produce monthly reports, and then we have formal M&M meetings, both monthly and every 3 months, to review the reports to see if there are any worrying trends with regard to particular complications such as necessity for second surgery on the same admission, surgical site infection, any unique things that we know may have clearly modifiable factors that we can deal with in a timely fashion. And as Dr. Chapman had alluded to, we published our initial experience in 2011, and prior to that, most publications would have said that the complication rate for major adult deformity was 3%, 8%. It's always certainly less than 10%. And I can tell you, we published this paper, and about 6 months later, I had a patient come to the clinic. And the patient had a degenerative scoliosis, and I spoke to them. We went through the treatment options. We discussed consent for surgery. And after all that, she turned to me and she said, "I'm not really sure I want to have my surgery done at Vancouver General Hospital." And I said, "Oh, why is that?" And she said, "Well, you guys have an 89% complication rate." And so the reality is, if you do this kind of work, and if you do it rigorously and honestly, you're going to find rates of complications potentially as high as that. Now, that 89% obviously included many medical post-operative complications, but also intraoperative. And really what it said to me, that experience, was that when we generate this type of data, it has impact beyond just the surgical group, beyond just the ward, beyond just the hospital. But the patients are getting this data, they're understanding it, and then they're coming to us asking questions about it. When we establish this system, obviously, first step is to determine its reliability, and you have to show that within your environment it's reliable, and that not just the surgeons, the other physicians, the nurses, nurse practitioners, everybody can contribute to this data in a reliable way. Interestingly, over the years that we've changed this system, we've come to realize that while it remains reliable for most things, i.e. identifying the adverse event, what we haven't got a handle on yet is reliably making that link between the occurrence of an adverse event and length of stay or outcome. And that gets back to one of the questions that Dr. Chapman's paper had raised earlier about the link between the occurrence of these events and ultimately what the outcome would be. One of the first steps we set out to do was to look at how this system compares with established hospital systems, so established hospital data systems such as ICD-10 coding. And what this study revealed to us was not only does a prospective physician and nursing team-led system identify more adverse events in a more timely way, but actually associations between adverse events and outcome, or between premorbid conditions and the occurrence of adverse events, are identified with a prospective system where they won't be by a hospital system. So what the importance of that is that the hospital may not recognize that it has a particularly at-risk population, or that it has a particularly at-risk practice if it's not able to identify these associations or links. And so I would contend that most hospital systems, based on their methodology of retrospective collection or identification of adverse events through chart abstraction, are doomed to fail as far as identifying these kind of associations, both for patient-specific and for service-specific adverse events. So when we looked at our particular unique populations in our initial couple of years of collecting this data, we wanted to look at, did it really matter? Yes, we knew that these occurred. It's difficult to link them to patient-reported outcomes, but we do have economic outcomes that we could look at and see whether the occurrence of these events actually makes an economic difference. And I can tell you that these are Canadian figures. They're relatively conservative as to the impact or effect of a single or multiple adverse events. But you can see that there's an incremental increase in cost for stay for patients when they have adverse events. A grade 2, 3 or 4 adverse events are adverse events that require some form of active intervention, reoperation, increasing level of care, being transferred from the ward to high acuity or to ICU. Those kind of events that have a significant impact. And you can see that those significant impacts can be very costly. And so identifying them, identifying the system things that you can address to try and mitigate against those is very important. So when you've generated that kind of data, you have that kind of understanding, now you have an opportunity to be a context expert. And with that context expertise, now you think, okay, now I'm going to go beyond the walls of my own hospital and I'm going to try and collaborate with people who are interested in the same kind of thing and see whether we can grow this to something meaningful that has impact outside of your own hospital. And so our first collaboration was with the Rick Hansen Institute, which is an institute dedicated to the care and the promotion of health in people who have traumatic spinal cord injury. And we're blessed actually that they have their offices in the same building that we have our clinics, and that's at the ICORD building in Vancouver, where you have clinicians, patients, a patient gym, biomechanics, basic science research, all in the same building. And so the opportunity to collaborate, the opportunity to discuss you can't go to the coffee shop without bumping into one of the basic science guys who says, oh, well, I just found this. What do you think of that? What do you think the clinical perspective is on that? And so to have that environment really enriches your ability to be able to collaborate. We did some collaborative work with them looking specifically at complications in traumatic spinal cord injured patients. And we were able to look at associations, risk factors, be it age, motor score on admission, depending on the degree of spinal cord injury, and looking at unique specific complications that they were experiencing and the rate of those. And again, similar to our prior papers and prior populations, we were finding rates of complications that were way, way higher than what had previously been reported. What does that do for you? Well, that gives us leverage to go to funders, in our case, to go to the Ministry of Health in British Columbia and say, we're dealing with a uniquely complex population of patients, and you try to advocate both for yourself and your patients to improve funding for that. You can also then demonstrate or illustrate that there are factors that are either sometimes non-modifiable, but some modifiable factors that increase a patient's risk for complications. And even if they're non-modifiable, at least that knowledge allows you to preempt it and know that patients with a high cervical injury who have a low vital capacity have a high risk of having to go back to ICU for reintubation or tracheostomy. And at least empowering yourself with that knowledge allows you to anticipate that. When we look specifically at our first population of patients, we wanted to understand why were we operating on these people a second time during the same admission. And the vast majority of them were either for surgical site infection or for hardware malposition that required revision. So we thought, okay, here's two T-balls, easy knockout of the park. They're going to have a huge influence. If we're reoperating on patients, that's something we should address. And to look at surgical site infection, we tried to create a framework to evaluate the risk factors for a patient for developing infection. We looked at surgery factors, hospital factors, patient factors. And so what we did was we constructed a model, a predictive model of a risk of infection based on a certain population of patients. And from that, we pulled unique characteristics of the patient, their hospital stay, their surgery, that predicted their risk of infection. And we were able to come up with odds ratios for infection. So interestingly, if you go to ICU after your spine surgery, your odds ratio for getting a surgical site infection is almost 2. If you develop a urinary tract infection in the first week post-op on the ward, your odds ratio of getting a surgical site infection is, I think it's 5.8, so it's almost 6 times higher. So a UTI on the ward puts you at a 6 times higher risk of getting a surgical site infection. Doesn't that seem like a fairly straightforward or potentially easy modifiable thing that you could address and therefore reduce that risk to your patient? And another thing, and I'll mention it later, is the surgical approach. We found that if you do midline muscle cutting approaches, your infection rate's relatively high. If you do lateral muscle splitting, less invasive approaches, your surgical site infection is lower, and I'll show you some data on that. So we essentially went on to develop this predictive algorithm that said, well, based on these risk factors, we could predict your risk for infection. And so we could identify the possible modifiable factors that we could tweak or change to try and reduce that risk. Speaking of this, the alternate or less invasive surgical approach, we were utilizing either this midline muscle cutting or this lateral muscle splitting. And this is just an intraoperative imaging showing the less invasive lateral or muscle splitting approach. And what we found was that we had, in simple 1 or 2 level lumbar fusions, we had a 4% infection rate or wound complication rate in midline approach. And we didn't have a single complication in the same number of patients who had a splitting approach. And this has fundamentally changed our practice in Vancouver. And I pretty much every patient who has a low lumbar degenerative condition, 1 or 2 levels now, has their surgery done by muscle splitting as opposed to central exposure, simply because of being able to eliminate that high risk of infection. Vancouver's a beautiful city. Many reasons why people flood there to live. But when we reviewed our data on complications, we identified a very unique population of people who live in Vancouver. And they're drug users in the downtown east side. And we have 30,000 drug users that live in a 14-block radius in one part of our downtown city. And their health utilization is huge. But their specific spine health problems are very unique and very challenging. They present with cervical epidural abscesses, osteomyelitis, significant deformity. And what did we learn about looking at this population uniquely as opposed to the non-IV drug user population? Well, the first thing is they never die in hospital. No matter how sick they get, they always manage to leave hospital. No matter how paralyzed they are when they come into hospital, they almost always get better. And once they leave hospital, they never come back for follow-up. So a very uniquely challenging population of patients who we really wouldn't have understood those nuances of their presentation, their requirements for treatment, and that were it not for this type of database where we were able to look at them specifically. Part of our work with trying to reduce surgical site infection was also collaborative work with the other services in the hospital, where we have moved to chlorhexidine washcloths preoperatively and, my apologies, nasal decolonization techniques to reduce patient contamination preoperatively. And of all the surgical services in our hospital have utilized this methodology for preoperative decolonization, spine has seen the greatest benefit. And we have seen a very dramatic, so 40% reduction in surgical site infection rate for the introduction of this technology. And again, that has significant cost impacts. And again, I'll suggest that $30,000 as an incremental cost for a surgical site infection is really lowballing what the cost of an infection is. But even with that lowball, you can see that there's significant financial costs to these complications, but equally significant financial gains to be made by identifying them and preventing them. So our second most common reason to reoperate was hardware malposition requiring revision. And so we went about with negotiations with our foundation to get funding for an intraoperative CT-based navigation system. You'll see Dr. Fisher, my senior colleague here, still has his novice badge. He hasn't quite caught up with the technology yet. And I have to thank Dr. Dvorak for all the x-rays across the top where the screws are in the canal or in the aorta. But these are not that uncommon. And significant hardware malposition requiring revision is a reality in most centers that do either large volume or complex spine surgery. And so what we wanted to look at was, would the introduction of some CT-based or some form of intraoperative navigation, because prior to this we had no intraoperative navigation, we utilized either fluoroscopy or plain x-ray, could that have an impact on the number of screws that were being misplaced, and so an impact on the second most common reason why we were reoperating on patients during the same admission? And what we found was that the use of this type of technology decreases all the total number of screws that are misplaced, the number that need to be revised either early or late, and the number that are misplaced and significantly symptomatic. So there's a reduction in the number. Does that really matter or make a difference? Well, we found that we had a learning curve for the use of this technology. We increased our case numbers. We're putting in more screws. We're doing them quicker, well, not quite statistically significantly, but we're doing them somewhat quicker. Our blood loss is less, and our total screw malplacement rate is much lower. But what we found that was really important, and this is important not just for the patients, but also all the staff in the operating room, is that the use of this type of technology, yes, it increases the patient's exposure to radiation intraoperatively, but it completely eliminates the radiation exposure risk to the staff. Because you're not using fluoro, you're using less plain x-rays, you don't have to stand in lead, you don't have to worry about radiation exposure to your staff. And you'll see here that, yes, there's almost a threefold increase in the radiation exposure to the patient, but a similarly almost threefold reduction in radiation exposure to the surgeons. Does the radiation exposure to the patient, is that impactful? Is that important? Well, the amount of radiation that the patients are exposed to is less radiation than what they would be exposed to if you sent them down for a post-op CT to check their screws. So actually, in practical terms, this increase in radiation to the patient is pretty much insignificant. But we're protecting the staff who are exposed to these cases every day, 5 days a week, 52 weeks a year. And to reduce that radiation exposure to the staff is a huge benefit. And so now this technology has become standard of care for pretty much all our cases. And now our staff don't have to wear lead, and the radiation exposure issue is pretty much eliminated. When we looked at the improved accuracy of the screws and the preventing reoperations, we tried to look at, was there a cost benefit to that? And so we developed an incremental cost effectiveness ratio of a reoperation that's avoided. And what we were able to show is that if you're in a unit that does 250 instrumented spine cases a year, and you use this technology, it will pay for itself. And in fact, it'll actually save you money in the long term because of the number of reoperations that you avoid. The other leading, complications or potentially modifiable adverse events we identified included delirium and post-operative psychiatric disturbance. Since that, we've introduced very rigorous prospective delirium identification models. And while we haven't been able to decrease the incidence of delirium, we've been able to significantly decrease the length of stay impact of the onset of a delirious episode, because you're able to shorten that by a significant amount of time by earlier identification. If you recall, we talked about urinary tract infection and the 6-fold or odds ratio of 6 increased risk of a surgical site infection. Well, at around that same time, our hospital was trying to introduce this CAUTI initiative, which was only catheterized patients who really needed it, take the catheter out as soon as you could. And this was done across the entire hospital. And what we found was the CAUTI initiative, it decreased our urinary tract infection rate in our degenerative population and in our other population, but in spinal cord injured patients, that protocol was totally incorrect, because these people have neurogenic bladders, and pushing them to take the catheter out early was actually ended up increasing their urinary tract infection rate. And so we were able to go to the hospital and say, you know what, yeah, this might be a great initiative for many other populations in the hospital, but it's not appropriate for our unique patient population. And our clinical team got a Clinical Excellence Award for the identification of this discrepancy in this unique population, and then advocating for that in the hospital. We've been able to leverage the hospital to provide us with intensivists who round on our patients every day, providing acute medical care post-operatively, and that's led to a significant reduction in acute care medical adverse events, and so length of stay. So then this brings me to the collaborative, and coming to speak at a venue like this, to a group like this, is always an opportunity to suggest improving collaboration. And I'll give you our experience of collaborative work across all the sites in Canada that are part of the Canadian Spine Society. And you'll see that there's multiple sites. You see no one in Canada lives more than 100 kilometers from the US border. And since the Canadian Spine Society registry collects prospective data on all patients seen at all sites where spine surgery is done across the country. And our SAVES, or our complications database, is the complications portion of that registry that's utilized. And even in our unit, the time commitment, the work commitment is considerable. So we talked about the 4 hours on a Wednesday morning rounds. The residents and fellows and the nursing staff record complications every time they do ward rounds. Research people come to the ward every day, interviewing the nurses and the patients to make sure the complications are identified. And I would say that the hourly requirement per week to collect this data, again, I would say that what we're reporting here is very conservative. What we found, and I'll caution with regard to collaboration, that what we found in the Canadian experience is it's so variable across units. And it's variable for many reasons, and one of the main reasons is having a local champion. If you have a local champion who educates people, who engages other people, who gets people behind them and gets the momentum, then you'll be able to contribute in a meaningful way to something like this. If you don't have that champion, if you're not able to create that environment where you see the value of it, then you'll be like many of the sites in Canada where less than 20% of patients had their data adequately collected. So it's a caution with regard to collaboration, because the collaboration requires the same kind of commitment. We now have this SAVES system running at multiple sites, not just in Canada, but when we have fellows come every year and when they work with us through the year, they literally take this system home. We have the system on an internet-based platform through the Rick Hansen registry, so our fellows, when they go back to Australia or the UK, can then start uploading their data and their patients' data to that once they get home. And this collaborative work got the NASA Outstanding Paper Award in 2015, where the group in Copenhagen essentially reproduced our work from 2011 to demonstrate that it's not healthcare system specific. So in the Danish system there, they saw almost the similar complication rates and similar problems within unique populations. And so important to say that it's not just the Vancouver experience, it's not just the Canadian experience, but actually it probably translates across much wider than that. And this is basically the framework of this platform that's used through Rick Hansen, where everybody can access and upload their data, and then it's centralized. And there's this almost a seamless integration between that and our clinic, because again, we have this benefit of being in the ICORD building where I run my clinic and see patients on the second floor, and on the sixth floor, there are number punchers upstairs who are live collecting our data as we put it in on a daily basis. And so having that infrastructure is really, really important. And our data has been used now as part of government ministry-led initiatives, particularly in BC, looking at standardizing trauma care across the province. And this is a very interesting project that we did with Rick Hansen, where we tried to create a model that simulated the journey of a patient from the moment that they're catapulted out of the windscreen of their car at 100 miles an hour until they get back to the community, having gone through acute care, surgery, rehabilitation. And so we tried to create or simulate this model. And you can see, if you're collecting this data in a really granular way, now you have input that you can put into this model that allows you to create hypotheticals and answer questions without actually having to make significant changes clinically. And so questions that we're asking now and data that we're generating now is, well, what if we had helicopters for first response in BC to pick up spinal cord injury and take them immediately to a place of definitive care instead of going to a smaller hospital, having delays in care? Would that potentially make a difference? Well, this model with the granular data allows you to predict the effect of that without actually having to institute a prospective study to find the result. Would improved accessibility in the community, would that improve patient outcome? Would that decrease the rate of pressure sores or decrease issues around heterotropic ossification? And would some collaboration or fine-tuning the transition between acute care and rehab make a difference to outcome? These are all questions that you can answer with this model system, this discrete event simulation model system, because of the granularity of the data that's input. I just want to finish with two things hot off the press. They're not in print, they're not quite presented yet, but I think they're important to share with you because they brought home to us some very important lessons that we learned again from collecting this data. So Canada, like every other country in the world, is seeing an increasingly aging population. And we talk about the spine impacts of that, and osteoporosis and operating on elderly sick people. But I'll bring your attention to frailty. and the impact of operating on frail patients and what that impact may have on outcome. And we've been able to do a study with the NISQIP data to look at the effect of frailty on outcome from spine surgery. And we intentionally chose the least possible frail patients you could find in the NISQIP database having the simplest surgical procedures done. And despite that, we found a very significant impact. So if patients are frail, as defined by either a modified frailty index in this case, they're more likely to die in hospital, they're more likely to have a complication, they're more likely to have multiple complications. And this is in a benign population undergoing relatively benign surgery. So a very important lesson that we must be aware of this, particularly with this increasingly elderly population. Not wanting to scare anybody in the room that's over 65 or anything, but. And sarcopenia, or the measure of muscle mass in your body, is a surrogate measure of how frail you are. We have recently found it's the single most important predictor of mortality in patients with metastatic disease of the spine who come for emergency surgery. So what happens is the patient comes in at 2 o'clock in the morning with a rapidly progressive cord deficit. You get them imaged and you see their spinal cord is compressed, but you have no access to all their other records. Their oncologists, they can't get all of those records, and you have to make a decision, should you be rushing this patient to the operating room to do an emergency operation? And what this study tells us is that if you take their preoperative CT, which you would have done to determine the lesion, and you measure the volume of their psoas muscle, it'll tell you what their risk of dying in hospital is, and it'll tell you what their risk of dying within 3 months is, irrespective of their primary tumor or their visceral or skeletal tumor burden. And so very important that here's a tool that you can use in an acute setting to make a critically important decision as to whether these patients should undergo emergency surgery or not. And the most recent thing and worrying thing we learned was we wanted to look at the effect of operating on patients out of hours on complications. And we found that the occurrence of any adverse event, the number of adverse events, your length of stay in hospital, and your chances of dying in hospital were greater if your surgery was done after hours, irrespective of your injury severity score, your age, your neurological deficit, or what injury you had. So if you controlled for all other things, but had your surgery done at 10 o'clock at night as opposed to 10 o'clock in the morning, you're more likely to die in hospital. So we thought, well, that's an important thing to know. We need to change that. So we actually went back, and I apologize, this is really small because we haven't tabulated this data into tables yet. But we went to the ORMUS data, which is our OR booking data. And we found it's not actually the time of the day that matters. It's the time difference between when your case is booked and when you get into the OR. It's the delay in access to the OR from booking to getting into the room that makes the difference, and not necessarily or discreetly the time of the day. So a very, very, for us at least, a very, very important system issue that we've identified that we need to address at our unit because it's having such a significant impact on outcome. So I hope I didn't bore any of you. That's my perspective a little bit on the journey that we've had and what we've learned, the things we've tripped over and the things we might want to do again. And again, this journey I think is so important that you start out small, but eventually you can contribute to big data to make meaningful system changes. And again, I'd like to thank the Seattle Science Foundation for the opportunity to come and talk, and I'm open to any questions other than the personal. I'll try and be as honest as I can. Thank you.